Welcome to Senior Focus. I'm Laurie from Meadow Center and I'll be your host. Here at Senior Focus, we hope to bring you news and information about aging well. Today we have with us Alan Bingham from Life Choice Hospice. Welcome, Alan.
Well, thank you, Laurie. Pleasure to be here.
Thank you. So what we're looking to find out today is, I guess, let's begin with what is hospice. Could you explain to us that piece first?
Yes, hospice is one of those words that has a lot of misconceptions surrounding it. But what hospice is a philosophy of care. And where hospice actually works is when all the curative things that doctors do to actually make somebody better become futile. And they look at this and they say, this person is at the end stage of their life. And we all get to an end stage of life. And basically within the next 6 months, they're probably going to pass away. They're going to die. So there's nothing we can do at this point in time that's going to prevent that. We can't fix it. So hospice is a philosophy of care that says if we can't fix it, what we're going to do is we're going to make the life better and richer for that person. So what you do is you stop all the curative types of things that you're doing. What you then do is you look after the pain, you look after the comfort, and you look after the person to ensure that the time that they have left becomes the most important thing in your life and their life. So that they can have a rich experience with their family and friends, whoever they choose, to make sure that that time is rewarding and not sort of locked up with a lot of unnecessary curative things that are not going to work anyway. The nice thing about hospice is that because it's a philosophy of care, it can be rendered anywhere. Now, that might seem kind of odd to say, but we have hospice patients in their own home, in assisted living facilities, in skilled nursing facilities, in nursing homes. We have them in hospitals. And you've probably heard of a hospice house. Mm-hmm. That's a special place which only has hospice patients in it. And typically they're very small and very nicely put together. But it can be rendered anywhere, even to a homeless person. So wow. It's a philosophy of care, and it's basically aimed at making sure that life is rich. And most people equate hospice with death, mm-hmm. but what it is it's making sure that from the time of that diagnosis and from the time that decision is made, right through to the death, that person's care is looked after properly. And that includes a whole raft of people, from the nurse case manager, through nursing, through aides, chaplains, social workers, even volunteers. And it's all under the care of a medical director. Mm-hmm. And what's really nice about this is hospice as a philosophy of care looks after not only the patient, but the family. So what you've got is you've got the patient and you've got us working as a team with this group of people, working with the family to prepare them at the same time. Mm-hmm. And the team stays afterwards. So after the person actually dies, the patient actually dies, the team stay and they look after the family and the close friends and give bereavement support. So you've got to think of hospice as more than just something that happens at the end of life. Right. It's something that makes life richer during that stage of life and looks after the family as well as the patient.
And I do think that's such an important piece, and I think that that's one piece that many people aren't aware of, is that 13-month, am I right? 13 months.
13 months afterwards.
So, and the theory behind that being that they're staying through each anniversary. Is that correct?
Correct. Correct. And we keep on following up. But it's even more than that. For instance, we've had patients who are in assisted living facilities, mm-hmm. and they've been in the assisted living facility for many years.
Right.
It's their home.
Right.
So what we've had is not only the family, but also the rest of the people sure. in that assisted living facility, staff, all the other people in that community.
Yep.
And we've had our chaplains and our social workers go back in there and work with the people in that community, in that assisted living facility, afterwards, months afterwards, mm-hmm. even doing memorial services for staff yeah. in the assisted living community. So it's, as a philosophy of care, it's looking after the community that that person focuses within.
Right. That's a wonderful piece. Can you explain the difference between, I hear people talk about palliative care and hospice, and what the difference might be?
Good question. And a lot of people get it confused at times as to what palliative care is. Hospice is something that's described as being at the end stage of somebody's life within that 6-month period. Mm-hmm. Now, of course, somebody could, because let's face it, we never know when
Right.
somebody's going to die.
Right.
And some people, what we call graduate, they exceed the 6 months,
Mm-hmm.
and then we reassess them to see if they qualify or not, again, for hospice care. But some people do get better,
Mm-hmm.
which is wonderful.
Right.
But basically, hospice looks after that 6-month period, whereas palliative care is something that can go over a whole continuum of any person of any age on a longer-term basis.
Okay.
So I think that's the easiest way to think of it. Palliative care, and palliative care is also rendered under hospice.
Mm-hmm.
Palliative care looks after treating the symptoms. It doesn't try to cure something. It tries to manage the symptoms. So for instance, if a person's in pain, and it's a physical pain, because you can have emotional pain as well as other pains. So if it's a physical pain, we can manage the pain to a level where the person has the right level of cognition, so they
Yep.
understand what's happening,
Right.
and we can increase the medicine as they need it and decrease it as they need it, so that we can manage that pain perfectly. And that's what
Sure.
palliative care is. And that's where hospice fits in with palliative care, is in managing the pain, not trying to cure something.
I understand. So you've mentioned the 6 months, which appears to be a key piece of the hospice piece. So when does a family, or when does a patient, when do they know it's time? Because like you said, we can't sort of look in that crystal ball and know 6 months. So what are some of the triggers or the signs that we as family members and patients should be aware of?
Well, patients seem to be much more aware of it than family members. Often family members are in denial,
Mm-hmm.
and we face this all the time.
Mm-hmm.
And the first reaction is, oh, hospice, no.
Right.
My mother's not going to die.
Right.
Well, we're all going to die sooner or later. That's the hard truth.
Right.
But the mother, you might find, has already done some preparations.
Yep.
She's already looked out, and she's spoken to the local priest or minister. She's also organized her own burial plot
Mm-hmm.
in many instances.
Mm-hmm.
So she is seeing that there's something happening.
Yep.
How do you know? There's a whole bunch of different clinical indicators, and there's no one thing. But if you look at it, you look at some of the terminal diseases people have, from Alzheimer's through cancer, and people typically think of cancer as being the primary reason for hospice, yet we have more patients with end-stage Alzheimer's
Mm-hmm.
in hospice than we do with cancer.
Yeah.
People with renal failure.
Mm-hmm.
But then you look at general debility. Somebody's losing the ability to do things. They're not eating. They're losing weight. There are
Yeah.
all sorts of different things, and these can all form together in different degrees of severity.
Mm-hmm.
So it takes a medical person, and typically our medical director, who looks at what all the screens are, looks at all the symptoms of all the patients when they come through, and they're looked at by a nurse who actually does what they call screens them and says, do they meet these different criteria?
Sure.
And then it goes to the medical director who says, yes, this person, okay, meets the criteria.
Great.
And typically it's when anything else is going to be futile,
Mm-hmm.
and they can see that this person is in a decline,
Mm-hmm.
and it's going to be somewhere within that 6-month time frame.
Right. It seems as if there are some legal implications surrounding this as well.
Oh gosh, yes.
I would think, and I'm wondering if you might be able to speak to that. And one of the other questions I have too, which I guess is a piece of that, is who is able to make that decision? I'm guessing it's not uncommon for somebody to be unable to make that decision for themselves. So how does that work?
Right. People typically make the decision for themselves up until the time when they lose the ability to do that.
Mm-hmm.
So legally, the best thing that what you can do is have what they call a healthcare proxy.
Mm-hmm.
Now, the healthcare proxy is somebody that you know and trust, and somebody that knows what your wishes are,
Mm-hmm.
all right, and is prepared to go along with your wishes, not their wishes, your wishes.
Right.
And this is a legal document, and when the patient loses the ability to make those decisions themselves, the healthcare proxy can then make those decisions and direct the medical care and the care that's going to come to this particular patient according to their wishes.
Right. Right.
Now, there's another implication coming through right now. It's called MOLST, which is Medical Orders for Life-Sustaining Treatment.
Okay.
And this is an initiative that started over on the West Coast many years ago, and it's come through now. And here in Massachusetts, we're trying to have this all in place by 2014.
Wow.
Hospitals are working on it, skilled nursing facilities are working on it, the whole healthcare spectrum is working on it. EMS have been trained in it. And it's a simple form that basically has all the medical orders and the wishes of the patient put down on a piece of paper, which is two-sided in a very hot pink, so it's easy to see. And that is a legal medical document. It's a medical order, and it's signed off by the doctor as well as the patient. And so this will clarify the situation for people legally going forward in the future. And a number of places have already invoked this, and that actually supersedes the healthcare proxy.
That's interesting. I didn't realize that it supersedes that. That's interesting. And so one of the questions I have, one of the numbers, some of the statistics that I was looking at recently talked about how many people, when asked the question, would like to have their last days in their home, and how rarely that happens. And that was a startling number to look at, to see, you know, how often the wishes are not what actually plays out. Why do you think that is? Do you think that, so I'm wondering, do you think that this form is going to then help with that?
Well, it's been shown to help with that actually over in several of the western states. And I'm thinking it was Oregon, where they showed that in the last quarter, in several facilities, 100% of the last wishes of patients were actually carried out.
Oh my goodness.
So it was almost a perfect score.
Wow, that's extraordinary.
So yes, I'm sure it will help because people are unaware, but the essence of the form is that that's just a piece of paper, and that documents what the wishes are. What's really important is that the patient and the family discuss this so everybody is on the same page and there are no surprises.
Right.
Because the family need to know this too. They need to be able to support what's happened. They need to buy into that decision, and then the form just merely documents that. So that then becomes the documentation of the decision. The decision should be made first.
Right.
And that's a discussion that should take place with the family, with the patient, with their doctor. Because the doctor's going to sign the form too.
Right.
And so everybody's in agreement, everybody knows what's on the form, everybody knows what's going to happen. And if you look at the numbers, AARP said that in a study they did, 89% of the people they polled said they would rather die in their own home than anywhere else. And that was quite a broad statement. And yet only about 8% of people die in their own home.
Right.
Because that's what happens is people get rushed into the ICU. They get rushed to the ER, they stop breathing, they've got difficulty breathing, something's wrong, they're having a stroke. They rush them into the hospital, they get admitted, and then they get what they call tubed and wired. I don't know if you've ever looked at an ICU, and I know that people out there in the real world have seen so many things like ER on TV, where you see them and they're busy pumping on the chest, and they're actually a lot harsher than that. They're pumping on the chest, and then they're putting a thing, intubating people, putting a thing down their airway so that they can breathe, and then they're pumping air in. And you can imagine this happening to a frail 100-pound or less 90-year-old woman, for instance, who's probably got osteoporosis. They could break ribs. And then what they do is then they put the person into an ICU, and they wire them up with all sorts of electrodes and tube them with all sorts of different things that they're tubing them with. And you look at this person, they're surrounded by wires and tubes and flashing lights and digital readouts, and you know that this isn't what they really wanted.
Right.
Because what they wanted was to die peacefully at home.
Right.
And I had a friend who died in one of the major hospitals down in Boston, and she said that, I do not want to be intubated. I know if I get intubated, I will never wake up. To me, that's what's going to happen because of all the things I've got wrong with me.
Right.
And against her wishes, her daughter had her intubated, and sure enough, she died 2 days later, never woke up, never recovered. She didn't want that because she wanted the final time that she had to be able to communicate with her friends and relatives. And she was denied that.
Right. Right. So it sounds like that we're moving in the direction of making sure that those wishes are documented and are known by all, and not only that, but carried out.
But carried out as well.
Carried out is the big
Yes.
piece.
And that's the
Absolutely.
essence of it. At present, a lot of those wishes are not being carried out.
Right. And at the risk of getting into all the nitty-gritty, but I think this is important, can you talk a little bit about some of the costs associated with hospice, and how does that, because that is a big concern, the financial piece is going to always be a big concern. So could you
It
speak
is.
a little bit about the cost of hospice and how that works?
It is, and healthcare here is just so terribly expensive. But the beauty about hospice is that this is a Medicare benefit. I'm not sure if you're aware of that, but anyone who has Medicare can qualify for hospice. And what that does is it pays for everything. It will pay for any durable medical equipment, special things, for instance, like chairs or air mattresses or something like that that they might need. It will also pay for all the medications. So this is something that's very special. It's a Medicare benefit. There are some people that don't qualify, and those people are a very select, small group of the population who were excluded from Medicare for some reason or other. I don't know why, but typically it's some teachers and some railroad workers.
Wow.
So they don't qualify under Medicare for some reason. Now, what Medicare does not pay for is room and board. So if you're in your own home, that's fine. If you're in an assisted living facility where you're already paying for room and board, that's fine. But if you have to go to a hospice house, all right, then basically your room and board has to be paid for by somebody. Now, if you meet what they call the general inpatient, GIP level, which means your symptoms are totally out of control and you need to have somebody, a nurse specifically, a licensed nurse, hovering in the local vicinity, ready to work with you to manage your symptoms continually, 24/7, then basically, then your room and board is paid for too.
And that's paid for by Medicare? Is that, if you meet that criteria?
That's paid for. But then, as soon as your symptoms come under control and you go back onto standard hospice, then you actually have to pay for room and board as well.
I see.
So that's the only thing that you have to look at is the room and board.
Sure.
And if you're in a skilled nursing facility or in some other facility where you normally, or a hospice house, then you'd have to pay for that. But apart from that, everything is paid for by Medicare.
By Medicare.
And that includes not only the care, but includes the whole team, including the chaplains and the social workers, and it includes looking after the family for that at least 13-month period afterwards.
I was just going to ask that, so that part's included as well.
It's all bundled in.
That's fantastic. Right.
It is. It's a wonderful benefit.
Yep.
And people should be aware that this is something that they can get. Of course, we have Medicaid, Mass Health here in Massachusetts. A lot of people qualify for that. And the other thing I'd like to mention here is if you're a veteran, there's no minimum age. So what the VA do is that for Medicare, it's got to be 65. But if you're a veteran, and we've had a number of veterans come in at a very young age, unfortunately, and what the VA will do is they will put them directly into hospice.
I see.
And they've actually transformed that into Medicare.
And so in that scenario, the VA would be paying, is that
The
correct?
VA will pay for that, yes.
Okay. Okay. Wow, I didn't realize that piece of it. One other thing I wanted to ask about is there are a number of different hospice organizations out there. This is probably a tough time for families to be shopping and be consumer savvy. So do you have some advice for people that are trying to decide, where the decision has been made that hospice is the way to go, but trying to decide which hospice to choose? How do they differ, and how can somebody go about making those decisions?
I think the best way to look at this is that there's a standard package of things that you do with hospice. And these are things that are reimbursed by Medicare. And you've got to think of that as being the baseline.
Okay.
Now, there are some organizations out there that basically work at the baseline. Well, we see everybody as being unique at Life Choice Hospice. So we do things a bit differently, and some other organizations, some other providers probably do the same, but I haven't seen it to the extent that we do it. We look at everybody as having specific needs and specific wants. So we actually look at what their needs are on a unique basis. And we've done things especially things like aromatherapy.
Yep.
We do hand reflexology. We do all sorts of alternate therapies and complementary therapies that sit on top of the base.
Mm-hmm.
We have tapestries, which is a special Alzheimer's care that goes above and beyond what that base is. And we also have something we call inspiring events.
Mm-hmm.
Now we have a non-profit, a 501c3 that's attached to us, and basically we get a lot of bequests and donations that come into that. So what we do is we take that money and we redistribute that out amongst our existing patient base according to their needs. And I can give you some examples of
like
this.
that.
We recently had a med flight where we took a patient back over to California on a return med flight trip, which was many thousands of dollars.
I bet.
So he
Those are
could be with
expensive.
his family when he passed away.
Wow, that's wonderful.
We took a man recently for a ride on a Harley Davidson.
Oh, that's great.
It's something that was in his bucket list, and he always wanted to do this. We had a long-term patient who was at a skilled nursing facility, and she'd been there as a long-term care patient for several years. And she loves Chinese food.
Mm-hmm.
And she was she said to us, I can't get Chinese food here. I haven't had Chinese food for several years. How do I get Chinese? So we went out and we bought a Chinese banquet in for her.
Oh, that's great.
So we do things like that.
Sure.
These we call inspiring events. These are things that make this period of life richer for the person.
Sure.
So we look after the patient that way, and we look after their unique needs. And we assess everybody's needs on a continuing basis so that we keep on providing the care that they need. And that can be a spiritual care, it can be a physiological, a psychosocial care, it's also the clinical care.
Mm-hmm.
So I think when you're interviewing a hospice, you've got to be able to say, what are you prepared to do over and above the baseline care for my mother, father, loved one?
Sure. That's a great approach.
And then assess what their answer is.
Yep. That's a great approach, making sure it's personalized and acknowledging the life that they've had and the specific wants that they have.
Yes.
Fantastic. Well, that's great.
Right.
Well, thank you very much. I know I've learned an enormous amount. Thank you. And if you have any questions for Alan, please don't hesitate to call him. You can reach him at 978-777-822. Also, if you have any suggestions for show ideas or any questions for me, please don't hesitate to call me at 978-276-2010. And that wraps up our Senior Focus show for today. Take care.